All right. Thank you very much, Kendra, for that introduction. Hi, everyone. Thank you for joining us on the webinar today. Hopefully, we are going to have a great conversation about this very interesting and important topic. It is going to be about social determinants of health and diabetes. And let me try to advance my slide here. Oh, there we go. We are going to focus on a couple of things, as was mentioned in the previous webinar flyers. We're going to focus on reviewing the social determinants of health frameworks. There are a few of them out there. And we're also going to go over some of the associations between social determinants of health and diabetes-related outcomes. First, let's start with the definition of social determinants of health so that we all are on the same page, knowing what we are talking about. One of the definitions used widely, especially in the United States, is shown in the Healthy People 2030 and in previous versions of it as well. It is defined as conditions in the environments where people are born, live, work, play, worship, and age. And these conditions affect a wide range of health functioning and quality of life outcomes and risks. As we can see in this definition, the focus is on the conditions in our environments and leading to those health outcomes that are very important in everybody's lives. There's another definition used by the World Health Organization, though, and it adds another element to the existing definition. That element is more upstream, and they call it forces and systems shaping the conditions of daily life. And these forces and systems then include things like economic policies and systems, developmental agendas, political systems, and social norms and policies. As you can see in this definition, there are elements of those more upstream factors influencing the conditions and then in turn leading to the effects on the health outcomes. So this is the first definition, more pictorial representation of that definition used in the Healthy People 2030. These are the 5 domains used in the social determinants of health, healthcare policy, healthcare access and quality, neighborhood and built environment, social and community context, economic stability, and education access and quality. So maybe you like a more pictorial representation better. And if you're interested in learning more about the details of this, it is widely available on various websites. I included some of those at the end of this presentation as well. So let's look at these domains. I said there are a few different frameworks, social determinants of health frameworks. And the one we just went over, although it is showing as Healthy People 2020 here, the domains are still the same. The one that we saw in this circular representation, they are in the blue section of this framework. They are still the same. And the World Health Organization version that we went over in describing social determinants of health is represented over here. And this was the part that I mentioned that it is more upstream, includes more society level, comprehensive policies and factors. There are a couple, as public health professionals, you might be more familiar with other frameworks that might be used in county health rankings model or Kaiser Family Foundation models. All of these include, many of them include similar things, but they might be representing, for example, healthcare access seems to be a smaller aspect here, but it is covered in different ways. I'm going to go over next. versus in the model that we use in the United States more commonly includes specific things under the health and healthcare, for example, access to primary care, health literacy, and things like that. So under each of these domains that we looked at in this slide and in the previous one, for example, economic stability can include things like employment, food insecurity, housing, poverty indicators. Education can include early childhood education as well as adult literacy levels, high school graduation as indicators, language and literacy levels. Social and community context can include factors such as civic participation, racial discrimination, racism and discrimination, incarceration factors, and social cohesion, social capital, elements like that. In terms of neighborhood and built environment, then this domain includes factors such as access and availability of the foods, that support healthy eating patterns for people, neighborhood level crime and violence factors, environmental conditions in our environment, including toxic elements in the environment, and quality of housing. So let's look at, next I would like to go over a little bit more detail in terms of the World Health Organization model, because what that model does is it includes, in addition to outlining these factors within the domains, it also includes the builds up causal pathway. It shows how these factors are linked to one another. So this is the original model they developed under the World Health Organization. This socioeconomic and political context, this is the upstream element of that model, including governance, macroeconomic policies, social policies, like they can be things like labor and housing and land use policies, other education, health, or social public policies, or society level culture and values. So these are seen as upstream factors that then determine how individuals in a population are stratified by their socioeconomic position, their social status in the society. And this, what we see in this section, they call it part of structural determinants. And it includes social class, other social factors such as gender, ethnicity, racism also included in this element, and other economic structural factors such as education, occupation, and income levels. According to this model, then these structural determinants lead to the intermediary determinants and conditions that people are exposed depending on their position in the socioeconomic position measured by these factors. And these conditions or intermediary determinants can be things like living or working conditions, material circumstances, food availability, access to food, and healthy eating or unhealthy eating patterns. There can be behavioral and biological factors, including lifestyle behaviors, tobacco, alcohol use, physical activity, or even genetic makeup, because those can be influenced by the elements in our environment as well. And this intermediary level also includes psychosocial factors like social networks, social support, that can push the health outcomes then in a negative or positive way, depending on the situation. Now, I want to point out a couple of things here. As you can see, social cohesion and social capital is placed between the structural and intermediary determinants. It is because social cohesion, social capital can be shaped by the socioeconomic conditions that we see in the structural, the bucket of the social determinants of health framework, but also it has the elements, the individual's conditions and how it functions for individuals, and present itself as those conditions and behaviors and lifestyle patterns in the intermediary bucket of the model here. So that's why it is extending over both. Now, if you remember in the US, the definition and the model that we use in the US by the Healthy People 2030, healthcare system, healthcare access, and healthcare system was its own domain. It's a separate domain, right? Instead, in this model, they place the health system as it right here on the causal pathway between the intermediary determinants and the health outcome, final health outcome measures. It is because they posit that health system mediates these intermediary conditions leading to the health outcomes. So that's a very important kind of a difference between the WHO model and the other models that we are using. Another very important aspect of the World Health Organization model for social determinants of health is to notice these dotted lines and the arrows going all over the place. They indicate the causal pathways and connections between the factors. It helps us understand, for example, in this model, health outcomes is not the end of it all. It has a feedback system, feedback loop. It can actually have an influence on the societal policies, for example, depending on those health outcomes. And it can change the socioeconomic position of the person depending on those health outcomes. And some of these are double-sided arrows as well. So hopefully this gives you different ways of looking at these social determinants of health frameworks, different ways, and there are many applications and complex models as we try to work these different elements. I'm going to move on to the next one, and I'm going to pick one of those factors because social determinants of health has so many domains and so many indicators and so many elements in it. Sometimes we may think like one element, for example, education would lead us only in one direction on a linear way. It's not the case. And that's what I want to show on this slide. For example, when we take the education, it can affect those health outcomes in the end in many different ways. At the very personal, behavioral, and capabilities level, education can change a person's health knowledge, health-related behaviors, health literacy, and then in turn, these qualities and capacities can lead to changes in those intermediary outcomes that we were looking at in the previous slides. For example, dietary intake patterns, physical activity patterns, alcohol, smoking status, and disease prevention and management behaviors. On another level, education can also influence work-related conditions leading to changes in people's conditions, resources, and income, leading to changes such as exposure to hazardous situations, stress, work-life balance challenges, changes in health insurance coverage and benefits, for example, wellness benefits, or sick leave, retirement benefits. All of those things can influence one's lifestyle in the long run. It can also lead to changes in housing, neighborhood, and diet and physical activity options as well. And in terms of the social context, education can lead to changes in social support, social standing, sense of control, all of these social elements in our lives, and then conditions, intermediary conditions then would be changing, such as resources, social and economic resources affecting our everyday lives. Social norms can change in the society or community level, coping behaviors, health behaviors, family stability, and again, stress can be handled much differently depending on the social context and social support levels. All of these things in the end have influence on the health outcomes that we all try to measure and work with in our communities. Kendra, I see there is a raised hand. I assume you are monitoring that and responding to those, or do I need to be paying attention to that?
No, you can continue to present. Anyone that has a question, please use the Q&A feature at the bottom to ask your questions, and we'll check at the end of the webinar.
All right, wonderful. Thank you, Kendra. All right. So in addition to the multiple layers, multiple ways that these social determinants of health can affect the health behaviors, health conditions, and health outcomes in the end, there is another very important aspect of understanding social determinants of health. It is this cyclical and intergenerational aspect of this concept. For example, by social determinants of health influencing childhood factors, a child's health and growth rate and mental and social capacity and physical capacity, it eventually will have influences on that child adulthood health status and behaviors and capacity, and even influencing economic and other domains of the social determinants of health. In turn, then it will be reflected in the family unit's health. Then it goes back to the transfer to the next generations through those economic and social capacity and strengths and weaknesses in the family's life and the society, then it's passed on to the next generation. So I think this is really important to keep in mind, these lifelong and intergenerational and cyclical aspects of the social determinants of health. Now we are moving on. Hopefully, if there's any question about the social determinants of, I'll go back to this. Kendra, if you can let me know. I think we are going to take the questions in the end, but I'm going to stop defining the social determinants of health. So hopefully that give a kind of the short overview of the concept itself and the frameworks. Next, I'm going to move on to the diabetes topic and in relationship to social determinants of health. I think everybody on this webinar knows that diabetes is a huge public health problem. Is a tremendous health issue that we are dealing with either at the individual level or community or society level in every aspect of our lives, and especially in public health and nutrition world, it is one of those biggest issues. This is just some of the infographics provided by the CDC. 1 in 5 people, about 38 million Americans have diabetes, and 1 in 5 is basically undiagnosed. So there is a huge the undiagnosed diabetes, and in addition to undiagnosed diabetes, pre-diabetes numbers are even higher. I included on the right-hand side of this slide is the statistics for youth, children and youth and younger adult ages. 1 in 4 individuals age 19 to 34 have pre-diabetes. And of course, the consequence of this is there is even a bigger wave of diabetes coming down the road as we started facing this with the increasing rates among youth. We are going to be continue to face these issues in the future, because pre-diabetes is going to lead to diabetes if we don't tackle the social determinants of health and biological and other determinants of the diabetes outcomes. Now, looking at drawing connections between the social determinants of health and diabetes prevalence, I included a few slides by different factors that we looked at in the social determinants of health framework. So we are looking at the racial ethnic breakdown for diabetes prevalence. On the left side, it is the diagnosed diabetes coming from the National Health and Review surveillance system. And as you can see, it is not evenly distributed among different racial ethnic groups. Basically, many of the racial ethnic groups in our population, non-Hispanic Blacks, Hispanics, for example, Asian Indians, Filipino. So all of these population subgroups have increased levels of diabetes, diagnosed diabetes, and these disparities, it's very easy to see in these statistics. On the right-hand side, I'm showing the over time, what it is looking like. Did this thing happen in terms of the racial disparities in diabetes? Did it happen just recently, or has it been going on for quite some time? As you can see, it's been going on for decades. And one of the things I would like to highlight is, as you can see, in terms of the Asian Indian and some of the groups that are counted in the overall Asian category, not all subcategories are equal in terms of the disease, health disparities and disease prevalence, right? So this is one of those areas. This is gray line is representing the non-Hispanic Asian population. And I want to draw your attention to the upright increase in that category and separation of the lines over the years, basically representing the different levels of diabetes among different racial ethnic groups here. And lowest diabetes prevalence rate has consistently belonged to the non-Hispanic white populations in the purple bar. So if we look at these racial diabetes disparities a little bit more in detail, Hispanics is it's not a Hispanic or Latino populations. It's not just one group, right? There are many different people coming from different regions. And as you can see, these are reflected in the diabetes numbers as well among Hispanics, Mexicans, Puerto Ricans, Cubans, Dominicans. They have very higher rates of diabetes prevalence. And this is in the earlier years, we did not have such breakdowns, but in the more recent years, US Census started dividing and giving us more information about the subcategories of some of the racial ethnic groups in the United States, at least. So this is the benefit of that, looking at those groups, and South Asians really top the charts in terms of non-Hispanic Asian subgroups here. So we have large segments of the population, 23% of the population, Hispanics and non-Hispanic Asians account for of the US population. And they are, as you can see, at a higher risk for diabetes. So it is definitely a public health issue that we need to pay attention and address. These two charts, these are diabetes prevalence by race ethnicity among youth. I also wanted to show this because those racial disparities that we see in the previous slides is not specific to just adults. We already see these differential prevalence patterns in youth as well. This teal colored line among 10 to 19 years old people for type 2 diabetes prevalence is Black, non-Hispanic Black population. So we definitely see these in different age groups, both children, youth, and adults. Now, continuing on, looking at different social determinants of health in relationship to diabetes, percentage of diabetes that we see in the population. This is using the federal poverty line. As you can see here, as the poverty line goes, less than 100% of the federal poverty level, it has the highest diabetes prevalence numbers, and as the income level in comparison to the federal poverty levels goes down, the prevalence goes down as well. This is by education, kind of a similar pattern, less education, more diabetes. Blue bars are the diagnosed diabetes, and red bars or brownish colored bars are the total diagnosed and non-diagnosed diabetes. And we see similar patterns in both. As the education level goes up, the diabetes prevalence numbers go down. And again, looking at these patterns over the years, again, we see this separation in the green line, having less than high school education. This group has the highest prevalence rates over the years in terms of diabetes. Now, whichever I think in public health arena, we know that there are different measures of socioeconomic status. And what I included here are those different measures, whether you're looking at it by education attainment or by income level or by participation in the federal assistance programs such as SNAP, or by poverty level or college education or income by itself. All of these things are related, not just diabetes as the prevalence or incidence of diabetes, but this one, for example, highlights the conversion progression to type 2 diabetes, mellitus, diabetes-related mortality, or diabetes management, diabetes complications are also linked to all of these socioeconomic factors, HbA1c being a measure of blood glucose management. Looking at a couple other aspects of social determinants of health in terms of socioeconomic domain, employment and occupation come to mind, right? We also see higher diabetes prevalence among unemployed or populations, individuals with high job insecurity. We also see higher diabetes rates among shift workers and those who work long hours, 55 or more hours per week. But we see this long hours effect only among those with low socioeconomic status. We don't see the same effect among people with high socioeconomic status. So there are those differential outcomes depending on other additional factors. Interestingly, this was different professions or occupations in relationship to diabetes. In a Gallup poll, they asked self-reported diabetes and they compared those to different professions. And interestingly enough, transportation workers, farming, fishing industry workers, service industry workers, clerical and manufacturing workers topped the list. Transportation workers basically was the number one in the list, highest self-reported diabetes. Lowest profession in terms of the self-reported diabetes in the list was physicians. And the construction workers were pretty close to it too. So maybe we can discuss why these two are in the same category. You might be thinking, so I took this chart from Hillenbriggs and Fitzpatrick's wonderful paper. They looked at influence of racial, ethnic influence in terms of the diabetes and racial ethnic differences, disparities, and discrimination and racism issues. And they presented this with permission from Braveman paper. They presented this because you might be thinking, okay, certain minorities might have more diabetes because they might have higher rates of low socioeconomic status. So is it just a race, or is it the socioeconomic status that is being the greater influence on diabetes outcome, having this disease? So that's why I think this graph is really important. It is showing us that in terms of, even when we split the socioeconomic status between the bars, so this is everyone, but then they split it between Blacks, Mexican Americans, and whites, 3 racial ethnic groups, and stratified it by the income level and according to the federal poverty level. So in every category, not in every category, but in Blacks and Mexican Americans, the lowest income level by the federal poverty level had the highest prevalence, highest percentage of the population with diabetes. So we don't see the same pattern among whites. So this highlights those socioeconomic elements, even when you're looking at different racial ethnic groups. So it is not just one or the other, it is both, but to what degree that can change from one population to the next. Another way to look at it, this is from the Cromer paper, they look at a similar kind of a thought. They wanted to look into the combination of genetic effect of genetics, because diabetes prevalence can be influenced by the genetic factors and family history of diabetes, which may or may not be about genetics always. But they examined the differential effects of the two, socioeconomic status and genetic risk. So in the horizontal line, we are looking at the genetic risk going from the low risk to the high risk. And within each category, the blue bars that represent the low socioeconomic risk, and the warmer colors, like orange colors, represent the higher socioeconomic risk. So if you look at the low genetic risk category, the difference between the low socioeconomic risk and high socioeconomic risk is about 1.7%. When you go to the high genetic risk category, the difference between low socioeconomic risk and high socioeconomic risk is about 9.2, so much higher. So this also shows us that there is an interplay of these multiple factors, but sometimes these factors, in this case of the genetic factors, the effect of the socioeconomic risk is multiplied, and it gets larger and larger. It doesn't remain the same. All right. Looking at another social determinants of health, housing instability, and diabetes prevalence. The research is not a lot in this field. There isn't a lot looking at the housing instability, most probably because of the difficulties of studying these outcomes. But the information I included in the slide, again, coming from the Hill, Briggs, and colleagues, wonderful review paper they published in 2021. They reviewed many of these factors, and I highly recommend you all to read that paper really carefully. They have done a wonderful job, and I'm personally very thankful for their work and publishing the results. So they also included some of the research coming from potential influence of social determinants of health in terms of diabetes outcomes, comes from the studies where they gave Section 8 vouchers, housing vouchers to people, and they did have different arms of the study. One was the usual care and the usual practice. Another one, they gave the same vouchers to people, but they let them decide where they would like to use those vouchers. And in the third arm, they mandated to people the vouchers could be used only in low poverty census tracts. So better neighborhoods, in other words, economically, better to do neighborhoods. So interestingly, they found those vouchers that could be only used better neighborhoods led to better control of blood glucose measured by glycosylated hemoglobin, and actually better outcomes in terms of excessive body weight, BMI of having more than 35 or more. And these kinds of changes, these outcomes were also linked to better housing quality, education, employment, and earnings being changed in the new environment. In the long term, they actually showed sustained reductions in extreme obesity and improved mental health outcomes. Another social determinant of health, we often talk about built environment in terms of diabetes. Many research papers have been published about obesity, dietary patterns, physical activities. Those are physical activity levels. Those are, of course, factors related to type 2 diabetes risk specifically. But in this one, I was looking at the diabetes as the outcome. Walkability and access to green spaces in a neighborhood in the built environment has been linked to lower risk of type 2 diabetes. And in our environment, there is also some research. There is still a lot to do in this field, but there is some research indicating that air pollution, other contaminants in our environment, like arsenic, phthalates, and bisphenols, so maybe we're not sure about that in relationship to type 2 diabetes yet. But these contaminants actually are linked to higher rates of cardiovascular complications among people with diabetes than the rates that were seen among people without diabetes. Talking about environment, we cannot skip over food environment, of course. The prevalence of diabetes goes down as access to food and availability of full service restaurants, grocery stores, and decreasing number of fast food restaurants and convenience stores that we see in the environment. So there is that reverse relationship. As the food environment looks better, the prevalence of diabetes also go down. And some research, they show the losing access to a supermarket over the 4 years resulted in worst glycosylated hemoglobin measures among people versus when when the neighborhood gained a supermarket, there was slightly better glucose management. But it's not a but, it's an and. It also linked to blunted increase in diabetes prevalence. So the changes were not really large, but they saw some small changes in that in terms of the positive changes. Affordability of healthier foods, this often comes in terms of the food environment discussions. I did not see in research direct link with diabetes, but we know that affordability of healthier foods linked to directly linked to diet quality of people. So the direct link might not be there, but it is most likely an indirect link going through the diet quality and lifestyle and ending results from there. So neighborhood socioeconomic environment and food environment are most likely two different things. So food environment does not necessarily mediate the neighborhood's socioeconomic environment. So they have their own separate effects on different outcomes. And these outcomes, depending on the research you're looking at, can be complex association because they can be influenced by other things in that community, such as the other socioeconomic factors, population density, and things like that. Another element I want to focus here in this slide is about food insecurity, because we know that food insecurity is a risk factor for poor diabetes management, metabolic control, hypoglycemia prevention, and especially in groups with low education and low income. There are different pathways leading to these outcomes. Some of them are nutritional, so affecting directly the food intake by influencing the diet quality and intake of consumption of energy-dense foods, or inconsistency in the access to foods can definitely directly affect, especially if the people are on insulin or type 1 diabetes. It can very easily lead to hypoglycemia episodes. Another pathway is the compensatory. It can present challenges to manage diabetes because of other priorities. Pressing priorities in one's life can prevent people from taking care of their diabetes needs and disease prevention and management needs. And also, there's also a psychosocial pathway by leading to decreases in self-efficacy and depressive symptoms and diabetes distress. This can also have physiological and social results, outcomes, unintended or negative results. Healthcare, of course, it is related to both the social determinants of health and diabetes outcomes. In terms of the healthcare access, definitely is one of those issues. When people are uninsured, when they don't have enough coverage, they're more likely to have undiagnosed diabetes, higher likelihood of not having glucose screening, blood glucose screening, or blood pressure checkups, or access to urgent care. And if they have diabetes, they are less likely to have office visits, those necessary preventive and maintenance level visits to take care of their disease status. And some research is showing that having both insurance and usual source of care is the best possibility rather than having one or the other. Affordability and quality of care, of course, are other elements in relationship to diabetes outcomes. Cost-related non-adherence can be delayed if people do not have adequate or quality healthcare access. And this non-adherence, cost-related non-adherence, 14 to 20% of adults with diabetes has been reported to affect the taking of the medications, and even higher for people who use insulin. In terms of the quality, there is this additional aspect of the racial disparity as well. For example, Blacks receiving care, lower quality of care, even within, for example, the VA system. It's been reported, and disparities in screening and diabetes management exams and therapies have also been reported. Now, we are closing on, so I want to go over the social context of the social determinants of health. When there is increasing social capital, social cohesion, and social support, all of these things are related to either better diabetes control, better outcomes, lower diabetes incidence, or quality of life treatment of the disease. And social support interventions have been shown to be effective actually, regardless of who provides it, whether it's the healthcare provider or neighbor or a spouse, they all have positive results. And I think I'm going to, so we talked a lot of social determinants of health. So this is kind of putting the pieces together. And again, I want to refer you all to the paper published by Hill, Briggs, and Fitzpatrick in 2023. They really pull all these pieces together and present this framework in terms of how all of these social determinants of health, they are connected to one another, and in the end they lead to diabetes disparities, either in prevalence, complications, care quality, utilization, or mortality. In the last few minutes, I'm not going to read these one by one, but I want to highlight a few of the recommended resources and policy and practice implications. There have been some reports. One of those is Health in All Policies, put together by CDC and the APHA. And it's been used in the National Clinical Care Commission's report to the Congress about preventing and controlling diabetes and its complications. So it presents kind of strategies at the foundational level, what federal agencies can do for diabetes control and prevention, keeping the health in all policies and related social determinants of health in mind. At the population level, what strategies can be taken to have an effect on these, such as ranging from the consumer-friendly food labels, encouraging consumption of water instead of sugar-sweetened beverages, nutrition assistance programs promoting all food security and higher diet quality, expanding housing opportunities. So there are a lot of useful strategies they recommend. And they also recommendations for people with diabetes or at risk for diabetes. And I would be best if I did not mention the diabetes prevention program here. I think research has been showing the effectiveness of prevention programs, and now these policies are taking place as we speak, but there is more to do, and to make it more available, to have it covered by insurance and widely and easily available and attainable and by people. And including the supporting team-based approach and training the new members of the public health and healthcare community, increasing the workforce, and applying team-based care. So these are the major. One other thing, since I'm a researcher, I'm an applied researcher, I want to finish with recommendations for research and practice. This is coming from another federal organization, NIDDK. They also put together a wonderful list of recommendations for strategies, both for research and practice, including community engagement and working on exploring the relationships between social determinants of health, structural racism, discrimination that affect these disparities, and NIDDK diseases such as diabetes. It's one of those, it's in their name. And as researchers, I think we have a role to work on better ways, methods, measures, technologies, not only to understand these associations, but to implement the best practices and share that information with all the communities affected from these. So I included some additional resources here in terms of some of these I already used in forming these slides, and hopefully you found helpful. And if you wanted to read more in detail, I included these resources, including at the very top here, some tools. Some of you might be very well aware of those screening tools for social determinants of health, but I included a link here for tools and other resources here. Thank you so much. I'll stop here, and if there are any questions, we will try to answer them, and feel free to reach out to me. This is my email. If you have any questions or would like to continue the conversation, feel free to reach out to me. It's been my pleasure with this webinar, so I'll stop here. Kendra?
Yes. Thank you so much, Dr. Fitzgerald. This is a really great presentation and covering the importance of social determinants of health and how it ties in with diabetes. Well, first, I do have a question for you. Well, we had someone that mentioned the resources. Is the resources that you just shared, is that the back of the presentation? If not, are you able to share that with me and I could share it?
Yes, I believe it is.
Okay.
But if it is not there, I'll be happy to share. I am pretty sure it was there.
Okay, no worries. If it's there, I'll reshare it with the attendees. I do have a question. Where do generational trauma experiences such as redlining, food deserts, and decayed housing stock fall in these determinants?
I'm sorry, okay, now I see the chat. Okay, so there is definitely, thank you for that wonderful question, Juan. If I may call you Juan. Not you, Kendra, but I was looking at Juan's message on the side. But anyways, yes, these definitely are part of the social determinants of health. And more importantly, I think for the food deserts, I try to touch upon a little bit on the food environment piece of it. I think food deserts and food environment is changing as we speak. Since COVID, how we get our food has changed to a certain degree, right? So we are influenced by those changes in our environment too. So now in terms of the recommendations, one of the recommendations, actually, those couple of organizations that put out, I mentioned at the end of the presentation, it actually includes like digital access. So that is why there is a policy and push for everybody to have access to reliable internet, and so that they can access some of these resources. And it's not just about learning and participating in a variety of activities, but also it can be about accessing healthier foods and making them available. So I work with some colleagues, and we are working on these the online based access, food access issues. So I don't know if some of these can be potential solutions in the future, but it is definitely something to look into. Food deserts definitely has been a huge effect on dietary quality, and some of the issues like generational trauma experiences, redlining, and discrimination, and all of these that coming from the history and being experienced even today. It goes into that not only what we experience today, but also that cyclical and population level intergenerational aspect that I try to highlight earlier, because it not only affects one generation, but the next generation, how next generation has access to what kinds of resources, economic resources, and what they can do better for themselves. So these are definitely intergenerational and long-term effects in the society.
Okay. I have a question. How can policies and intervention address social determinants of health to reduce the burden of diabetes on vulnerable populations?
On which populations? I'm sorry, Kendra.
Vulnerable populations.
Vulnerable. Okay. Very good question. In terms of vulnerable populations, I think diabetes prevention program is really one of those programs I really like, and I hope it gets more, it grows, and being able to offer to more populations in like federally qualified health centers and other places. And in terms of the policy, I see this coming from different directions. Policy doesn't have to come from the governing bodies. Some of the policies come from what we learn in research and when we try to find solutions to it. And one of those things, models I really like is this peer education model. It's been used heavily in diabetes prevention and management, a community health worker or promotora or the health promoter, or many other names. It is called by many other names. Sometimes the healthcare system has gaps in them, reaching out to the most vulnerable populations. And in some of those cases, these kinds of community health worker or peer counselor models are really useful, because taking the representatives from those communities and working with them right in the community, it works both for the community's trust and acceptance of the program. At the same time, it builds capacity in the community. So it has many, many benefits. And these health promotora, or community health worker models have been really, time and time again, has been shown to be effective. I have been part of these models in the last 20 years or so. My graduate education was based on and started with those models 20 plus years ago. So I'm a firm believer of that. It's just one of those, but we still have ways to go.
Yeah, thank you so much. That was really great feedback. Well, I just want to be respectful of your time, Dr. Fitzgerald, and everyone that attended.